Hello, and welcome to this Sara Clinical Education Oncology podcast. I'm your host, Jervis Constanza. Today's episode features Sara Tolaney at Dana-Farber Cancer Institute in Boston, Massachusetts, and Virginia Kaklamani of UT Health San Antonio in San Antonio, Texas. They will be sharing highlights from recent data presented at the 2025 San Antonio Breast Cancer Symposium, including new clinical trial data and long-term updates for studies in patients with early breast cancer and locally advanced or metastatic breast cancer. This episode is part of a larger educational program entitled CCO Independent Conference Highlights of the 2025 San Antonio Breast Cancer Symposium. For more information on Dr. Tolaney and Dr. Kaklamani, along with a link to the complete program, including downloadable slide sets of the key studies, certified text-based activities, and on-demand webcast, please visit the notes for this episode. Now let's get started and hear from the experts.
We were really excited to see data in the metastatic HER2-positive setting in the HER2CLIMB-05 study. This study looked at adding tucatinib to trastuzumab and pertuzumab in the first-line maintenance setting. So patients got upfront taxane with trastuzumab and pertuzumab for 48 cycles, and if they had disease that was either stable or responding, they could then enroll into this study and get randomized to HP maintenance or HP plus tucatinib, with the primary endpoint being progression-free survival. About 12% had brain metastases at baseline, so patients were allowed to have small asymptomatic brain mets that could be either treated or untreated at time of enrollment. This is a bit higher rate of brain metastases in the first-line setting compared to what we saw in DB09, where it was about 6% and about 4% in Patina. I think that probably reflects some bias in terms of preference to enroll a patient onto a study that has a CNS penetrating TKI. The prevalence of de novo disease was 70%. This is a lot higher than we've seen in other first-line trials. Most of the other first-line trials had about a 50% enrollment of de novo patients, as we had seen in DB09 and Patina. It was very impressive to see that there was about an 8.5-month absolute improvement in progression-free survival, favoring the addition of tucatinib to HP therapy, so taking PFS from around 16 to almost 25 months with a hazard ratio of 0.64. I will say, however, the absolute PFS numbers that we're seeing here were a lot lower than I think many of us anticipated. It is important to note that only 45% of those patients in the ER-positive subset did receive endocrine therapy. You were allowed, per physician discretion, to add endocrine treatment, but it was a little less than half the patients that did so. That certainly could have brought down the absolute PFS for the HR-positive subset in both arms. The relative benefit across various subgroups is very consistent across all of these subgroups. And what I think was important to note is that the hazard ratio for benefit was larger in the hormone receptor negative patients compared to the hormone receptor positive patients. In the HR negative subset, the hazard ratio is about 0.55. The HR positive subset hazard ratio about 0.73. What's interesting, though, is if you look at the absolute PFS for the tucatinib arms, it's almost identical for the hormone receptor positive and negative patients. It's that the control arm is actually performing quite differently for the hormone receptor positive versus negative patients. Of interest, certainly, was what's going on with the brain, because here we know that this is a HER2 TKI, has known survival benefit in patients with brain mets. This is, however, the first-line setting, so I would caution you that CNS events are lower in this upfront setting. I think we're going to need longer follow-up to see these differences, because right now the number of events separating the two arms in terms of CNS events is quite small, and OS data is highly immature at this time point, but a very nice trend favoring the addition of tucatinib. I took away from this trial that adding tucatinib to HP maintenance should be practice changing. It is clearly improving PFS across these patients. I think the question, though, is how do we integrate it into the first-line metastatic HER2-positive setting where we do have lots of choices? And I think it's also important to factor in toxicity, because we do know that diarrhea and hepatic toxicity are common side effects with tucatinib. And in fact, there were more discontinuations and more high-grade events and serious adverse events in the tucatinib arm compared to the control arm. Most of the discontinuations were due to elevated liver enzymes, as well as some due to diarrhea. The overall rate of diarrhea was about 70% in the tucatinib arm, with about 6% grade 3 events. And looking at the LFTs, about 25% of patients do get elevated LFTs. Onset for hepatic toxicity, it's about 40 days, and for diarrhea, about 50 days. So putting this into context is important because we've previously seen data from the PATINA study, which had looked at adding palbociclib as maintenance to HP endocrine therapy in that first-line ER-positive, HER2-positive setting, where we had seen a significant improvement, about a 15-month absolute improvement in PFS from the addition of palbociclib, and we're all highly anticipating a potential approval for palbo in this upfront maintenance setting. But one question that we've all wondered about was, does palbociclib have an impact on rates of CNS events? I think particularly relevant given what we just saw with tucatinib. And so the investigators from the PATINA trial did look at this. I would, however, caution, as we do look through this data, that there was no mandatory CNS imaging in this trial. So no mandatory CNS imaging at baseline, no mandatory CNS imaging in the follow-up setting, or at time of progression for those patients who did not have CNS metastases at baseline. This is different than HER2CLIMB-05, where mandatory CNS imaging was required even in those patients without baseline brain mets. They were required to get it at baseline and every 6 months and at time of progression. And so I think you have to interpret the PATINA data as more real-world data with not the same level of evidence as the HER2CLIMB-05 data would have for CNS events. But I think really important data to see the cumulative incidence of CNS progression. Looking at the palbociclib arm, there were fewer CNS events within the palbo arm compared to the control arm, so 14% compared to about 20%. This is fairly consistent in terms of benefit favoring the palbo arm compared to the control arm over time. And so this was also true for the patients who did not have brain metastases at baseline. I would note that only about 4% of patients had brain mets at baseline in the PATINA trial. Again, they were not screened with mandatory CNS imaging. Here, there's certainly a trend potentially favoring that palbo could be impacting that. Obviously, another potential choice for treatment in the first-line setting is now T-DXd plus pertuzumab. This combination recently FDA approved based on the DESTINY-Breast09 trial. This trial had taken patients in the upfront metastatic HER2-positive setting and randomized them to get T-DXd with or without pertuzumab and compared it to the Cleopatra regimen, THP. The study had demonstrated that at an interim analysis, the T-DXd pertuzumab arm had led to a significant improvement in progression-free survival compared to THP, with a PFS of a little over 40 months compared to 26 months, again leading to its recent approval. The T-DXd monotherapy arm still remains blinded, and those patients remain in follow-up. So while we do have this regimen approved, certainly one question is, what is the impact on quality of life? One would imagine that getting upfront induction treatment with THP followed by HP maintenance may be better tolerated because patients aren't continuing to get cytotoxic therapy until time of progression. These data were important because it did look at PROs. What was interesting to me when looking at these data is when patients were asked how bothered they were by side effects from treatment in each arm, the similar percentage of patients reported being not bothered at all or a little bit within the T-DXd plus pertuzumab arm compared to the THP arm. And there was similar reports of tolerability with the Patient Global Impression of Treatment Tolerability Scale. We also saw there were no differences in risk of clinical meaningful deterioration and pain between two arms. And there was, however, more impact of T-DXd pertuzumab on GI toxicities, where we did see more appetite loss, constipation, and nausea and vomiting with T-DXd and pertuzumab compared to the control arm. Seeing DB09, PATINA, and HER2CLIMB-05 data all at San Antonio does lead to a really robust question about what should we be doing in the upfront setting for our patients. Another trial that was highly anticipated at San Antonio was the ASCENT-07 study. This trial was trying to move sacituzumab up earlier for metastatic hormone receptor positive breast cancer. We obviously have sacituzumab approved based on the TROPiCS-02 study, which had demonstrated an improvement in PFS and OS in a pre-treated population. But this study was looking to see how sacituzumab compared to chemotherapy in patients who had only progressed on endocrine treatment, not any prior chemotherapy. And so patients were randomized to sacituzumab or treatment of physician's choice chemo, with the choices being capecitabine, paclitaxel, or nab-paclitaxel. And the primary endpoint was progression-free survival by blinded independent central review. The majority of patients had prior endocrine therapy with CDK4/6 inhibition, about 90% of patients, which would be consistent with our current practice patterns. I think we were a little bit surprised with this finding, though, is that there was absolutely no difference in progression-free survival between sacituzumab and standard chemotherapy in these patients who were chemotherapy naive for metastatic disease. The blinded independent central review PFS was a little over 8 months, but identical between the two arms at 8.3 months. It is really important to realize that there were patients who were randomized to the control arm who did get censored, so they pulled out of the trial prior to BICR confirmed PFS, and more of them went on to get a subsequent ADC. When talking to the investigators, they did feel that the investigator-assessed PFS that was occurring at these time points was really due to seeing new lesions that were seen, just not meeting BICR confirmed events. And so here again, you are seeing higher use of subsequent ADC in the control arm at about 60% compared to 30%, reflecting what many of us would anticipate in this study where it's not blinded to drug. Objective response rates are fairly similar between the two arms. Duration of response is actually longer with the sacituzumab arm compared to chemo. Again, really intriguing because we continue to see the signal with sacituzumab that duration of response seems to be much longer with this agent, making me wonder if there is an immune-based mechanism to the ADC leading to this. When you look at treatment discontinuation, it's fairly similar between the two arms. There were more grade 3 adverse events with sacituzumab compared to chemo. Toxicity profiles in line with what we already know with sacituzumab, certainly high rates of neutropenia, more grade 3/4 neutropenia, more in the way of diarrhea compared to chemotherapy, but less in the way of things like neurotoxicity. There was a difference for PFS based on investigator-assessed PFS. So again, the study does not conclude that sacituzumab is better than chemotherapy, and so will not change practice patterns, but will lead to sacituzumab being used in a pretreated population for metastatic hormone receptor positive disease. If we switch gears and think about the triple negative setting and data we've seen with TROP2 directed ADCs, this has been an exciting area given that we've seen recent data both from ASCENT-03, 04, and TROPION-Breast-02 in this first line metastatic triple negative setting. We've seen the efficacy data previously presented, but at San Antonio, we saw the safety analyses. So again, ASCENT-03 compared sacituzumab to chemotherapy in the first-line setting for patients who are deemed to be ineligible to immunotherapy, so patients who are PD-L1 negative or have a comorbidity for which they could not get an immune agent. And they got assessed for PFS as a primary endpoint. And we've previously seen that sacituzumab did lead to a significant improvement in PFS with a hazard ratio of about 0.6. And have now seen these data actually published in the New England Journal. There were more deaths in the sacituzumab arm. There were 7 deaths that had occurred in this arm. 6 were considered treatment-related and did result from infection. When you look at this data more carefully, you do see that 5 of the patients who died of infectious-related complications did so without receiving any growth factor, and yet all of these patients with the current guidelines would have met criteria for administration of growth factor treatment. So I think just a very important reminder that when you're treating patients with sacituzumab, do consider growth factor utilization in patients who do have prior issues with neutropenia or have comorbidities or older patients. When you look at the exposure-adjusted analyses, you do see that there are fewer issues with thrombocytopenia, anemia, and neuropathy with sacituzumab compared to chemotherapy, but you do see more in the way of diarrhea related to sacituzumab compared to standard chemotherapy. When you look at the time to onset of neutropenia, it's not that different between the two arms, but you do see earlier onset of diarrhea with sacituzumab compared to chemotherapy. Use of primary prophylaxis did result in a significant decrease in rates of neutropenia. Ascento 4 was the study we had previously seen reported at ASCO that had demonstrated that the combination of sacituzumab and pembrolizumab resulted in a significant improvement in PFS compared to standard chemo pembrolizumab for first-line PD-L1 positive patients. And when we look at the toxicity from this trial, we can see with an exposure-adjusted incidence rate that actually there was less in the way of need for dose reduction or discontinuation of therapy with sacituzumab compared to the chemo pembro arm. There was less in the way of anemia, thrombocytopenia, and neuropathy with the sacituzumab, but more in the way of diarrhea and colitis with the sacituzumab. One really intriguing finding was there was also less in the way of immune-related toxicities with the combination of sacituzumab and pembrolizumab. I think this is particularly reassuring because we do worry about diarrhea as a common side effect with sacituzumab, and you would worry about issues with IO colitis potentially with sacituzumab, pembrolizumab, but that rate was not higher with the use of the combination compared to chemo IO. Again, with the neutropenia and diarrhea, two common side effects with the sacituzumab at median time to onset. It is shorter for diarrhea with sacituzumab pembrolizumab compared to chemo pembrolizumab, but time to onset of neutropenia is fairly comparable between the two arms. When we look at TROPION-Breast02, this was a trial that looked at datopotamab deruxtecan or Dato-DXd compared to chemo, physician's choice in the first-line IO ineligible population. We saw these data presented at ESMO that did demonstrate that Dato-DXd led to an improvement not just in PFS, but also response rate and overall survival when compared to chemotherapy. At San Antonio, we saw data that specifically focused on the safety analysis. When we look at any grade toxicities, they're fairly similar between the two arms, as well as grade 3 and higher toxicities, as well as serious adverse events, suggesting that this is fairly similar between the two arms, but there were fewer treatment-related discontinuations within the Dato-DXd arm compared to the chemotherapy arm. Two important side effects to keep in mind with Dato-DXd are mucositis as well as ocular surface toxicities. We did see mucositis occur in about 60% of patients, and this was despite the recommended use of Decadron swish and spit for prophylaxis, with about 8% experiencing grade 3 mucositis. For ocular surface toxicity, it was about 50% of patients that had ocular surface events, with the majority of these events being dry eyes. They did specifically also look at time to resolution and time to onset of these toxicities, time to onset being about 26 days for stomatitis and about 77 days for ocular surface toxicity.
So now we're going to turn to the early stage setting.
Monarch E, as we all know, is the adjuvant trial looking at abemaciclib in patients that had a high risk of recurrence. And this is an update looking at nodal status here. Now, all patients on Monarch E had at least one positive lymph node, but there were different categories of risk. So as a reminder, early stage HR positive, HER2 negative breast cancer patients randomized to either standard of care endocrine therapy or standard of care endocrine therapy plus 2 years of abemaciclib. Now, we had an update at ESMO with these results showing an improvement in overall survival, really a big deal in the adjuvant setting. But let's look at the nodal status, because there's always a question, especially as we're adding therapies and we're increasing the toxicity profile for our patients. Is it really worth giving these treatments even in our lower risk patient population? So they broke it down into N1, N2, and N3 disease. And again, the N1 had to have high risk features, so it was not all N1 disease patients. And as looking at both IDFS and distant relapse-free survival, you can see that there is a benefit that is persisting regardless of the burden of nodal disease. Now, when looking at the absolute benefit, the more disease burden you have, the higher the absolute benefit there is from the addition of abemaciclib. But even in that N1 high-risk patient population, there's a benefit with the addition of abemaciclib. Now, not only is a similar trial, but with ribociclib instead of abemaciclib, ribo was given at a lower dose compared to what we give in the metastatic setting, so 400 milligrams, and it was given for 3 years. Now, the other difference, which may be important, is that when we give a ribociclib to patients, we cannot give it in combination with tamoxifen because of the QTc prolongation. So in this study, the AI partner to ribociclib was a non-steroidal aromatase inhibitor. This study included lower risk patients that compared to Monarch E. It included some node negative patients, and all node positive patients were included in the trial. We also saw an update of this trial at ESMO showing, again, a continued benefit with ribociclib. But here they looked at several subgroups of patients. And part of what we were also looking at, which we've seen before, is this node negative patient population that has a higher risk of recurrence. Should we be giving ribociclib to these patients? So DDFS, DRFS was consistent with the benefit of ribociclib that we've seen in the past. The longer the follow-up, the longer these curves are separating, again, showing us a benefit with giving ribociclib for 3 years. And then when looking at the different stages of disease, there is consistency. And even in the lower stage patients, lower risk patients, stage 2A, there still is a benefit from ribociclib. As we're increasing to stage 3A, stage 3B, 3C, we're seeing at least the absolute benefit increasing. But there is a benefit in that lower risk patient population, suggesting that patients that meet the criteria for NATALEE, we should consider giving ribociclib to these patients. Something interesting that we haven't had a lot of data on. So far, we've had a small series from Dana-Farber looking at this, but who are the patients that develop metastatic disease that have been exposed to a prior adjuvant CDK4/6 inhibitor? And what are the characteristics of these patients? The patients that had distant metastatic disease, most of them developed metastatic disease to the bones, although liver was next. There's a numerical difference between the ribo arm and the non-steroidal AI arm, but it was a little less likely for the patients in the ribociclib arm to develop bone disease compared to the non-ribo arm, and so forth. It seems to be the typical development of metastatic disease that we see in hormone receptor positive breast cancers. There didn't seem to be a major difference compared to what we've seen in patients that have not been exposed to a prior CDK4/6 inhibitor. As looking at nodal stage, again, important to show that even patients with N0 disease seem to get a benefit from the use of ribociclib. These were higher risk node negative disease patients, but still had a numerical benefit that suggested that we should be giving ribociclib to these patients. So probably one of the highlights of SABCS was the presentation of the lidERA trial. And this was the first SERD adjuvant trial to be presented. So far, we've had tamoxifen, we've had aromatase inhibitors being given in the adjuvant setting. We shied away from fulvestrant because of the intramuscular administration. But now with the oral SERDs, this brings us into a totally new era where a lot of these trials are evaluating oral SERDs in the adjuvant setting. And lidERA is the first one to have data. So this was a trial that included stage 1 to 3 breast cancer patients. Stage 1 patients had a little bit of a higher risk than your typical stage 1 breast cancer patients. And patients were randomized to standard of care endocrine therapy or giredestrant. And this was given for the 5 years that we typically give these drugs. Primary endpoint was invasive disease-free survival. When looking at the characteristics of the patients, well balanced between the arms, I just want to point out here that the majority of patients on the trial had stage 2 or 3 disease. Only 12 or 13% of patients had stage 1 breast cancer. And this is important because this is the type of patient that was not included in the adjuvant CDK4/6 inhibitor trials. Because we're always going to be struggling once, assuming giredestrant gets approved in this setting, are we going to give giredestrant to these patients, or are we going to give a CDK4/6 inhibitor? There's this nice separation of the curve with an improvement in invasive disease-free survival favoring the arm that received giredestrant, with a hazard ratio of 0.7, a positive p-value, and there didn't seem to be a difference in efficacy whether the control arm received an aromatase inhibitor or tamoxifen. I'll point to the fact that the patients that had stage 2 and 3 disease clearly had a benefit from giredestrant, but not enough patients with stage 1 breast cancer included in the trial to show any benefit, although the trend was favoring giredestrant here. And all the other subsets seem to be, again, favoring the use of giredestrant compared to the standard of care endocrine therapy. Distant recurrence-free interval and interim overall survival, very premature, but you can see, at least in DRFI, a hazard ratio of 0.69 favoring giredestrant. And even in overall survival, even though this is premature, there is a trend to improvement with the use of giredestrant. This is going to be a trial that we're going to be seeing several other updates in the subsequent years that'll help a little bit more in solidifying these results. Now, as far as safety, you've seen the safety of oral SERDs in the metastatic setting, and this didn't really change what we've seen previously. Well-tolerated agent with a favorable toxicity profile. No major difference between the control arm and the giredestrant as far as toxicities. And most importantly, when looking at treatment discontinuation, 5% in the giredestrant arm compared to 8% in the standard of care endocrine therapy arm. Now, what are the potential adverse events? And relatively similar to what we've seen in the metastatic setting, there's some arthralgia, some hot flashes. And when looking at musculoskeletal disorders, again, there's a suggestion that there might be a little less with giredestrant compared to standard of care endocrine therapy, but relatively similar in rates compared to standard of care endocrine therapy. Now, there is some bradycardia that we've also seen with some other oral SERDs, and this tended to be mostly grade 1 subclinical, but something to keep in mind. And as far as the venous thromboembolic events, no difference, very, very small rate between the arms. And this brings us to the SOLTI 2104 trial. Now, as you've seen with all of these oral SERDs, we're using them in patients that are postmenopausal. And same with fulvestrant. And the question has always been, why do we not use them in premenopausal patients, since the mechanism of action is not really similar to what we've seen with aromatase inhibitors? And one of the concerns with oral SERDs, especially when we try to use them in premenopausal patients, is the development of ovarian cysts because of the increase in estradiol levels. So this was an attempt by the French group to look at elacestrant in premenopausal patients with or without triptorelin to see whether it's safe, but also whether it's efficacious. They looked at what we don't see very commonly. They looked at complete cell cycle arrest. And this was defined as a Ki-67 of less than 2.7%. And they gave elacestrant or elacestrant plus triptorelin for a 5-week period. This was a window trial. So they gave that to patients that had been recently diagnosed with HR-positive early-stage breast cancer, gave elacestrant or elacestrant triptorelin, and then patients proceeded to surgery after 5 weeks of therapy. Now, 5 weeks may not be enough time to look at ovarian cysts, but it is enough time to look at least preliminary efficacy from this approach. And when looking at that complete cell cycle arrest rate, there's a pretty nice rate of cell cycle arrest happening in patients receiving elacestrant. Whether they received it with or without triptorelin didn't really seem to make a difference. The Ki-67 change was 62% in elacestrant and 72% in the elacestrant plus triptorelin arm. Again, these were not supposed to be comparators between the two arms, but just present some preliminary data. And then there was a change in ER levels, which went down, and no real major change in the PR levels. Something else that we're looking at is also, how are these tumors evolving? Many of them are starting out as luminal A tumors, and once you give them therapy, do these tumors continue to be luminal A's? Do they change? And how about the luminal B tumors? The majority of the luminal A tumors remain luminal A's, and many of those luminal B's become luminal A while exposed to the use of elacestrant. They looked at some gene expression, and there was downregulation of several genes that we would have been expecting to. And there was also a decrease in the PAM50 recurrence scores, which is also suggesting that there's a benefit from using elacestrant even in premenopausal patients. Now, moving on to a trial that was presented initially at ESMO, a very interesting, complicated clinical trial that I feel will be changing our standard of care. But there was some updated results at SABCS as well. And this is the Destiny Breast 11 trial. So this is a trial in patients that have early stage HER2-positive breast cancer. They have high-risk features. So this was defined as either clinical T3 or more, and N0 to N3, or clinical NET as long as they had at least N1 disease, or inflammatory breast cancer. So these patients were randomized to 3 arms, T-DXd followed by THP therapy, and T-DXd was given for 4 cycles, T-DXd monotherapy for 8 cycles, and then dose-dense AC followed by THP, which was considered the standard of care arm. Now, the T-DXd arm was discontinued because it was shown that it would not have a superior efficacy compared to the standard of care AC-THP arm. And so the presentation really focused on T-DXd followed by THP versus dose-dense AC-THP. So patients received this treatment neoadjuvantly and then proceeded to surgery. When looking at the results that were presented at ESMO, there was an improvement that was statistically significant in the ITT population, HR positive and HR negative population, favoring the T-DXd followed by THPR. And that improvement went from 56.3% PCR rate to 67.3%. The rates of PCR were higher in the HR negative patients compared to the HR positive, and we've seen this in many other clinical trials, so this is not a surprise. But this is really showing us that 4 cycles of T-DXd followed by THP can improve outcomes for our patients compared to standard of care AC-THP therapy. So the updates from SABCS looked at interstitial lung disease, and obviously when we're giving T-DXd in the metastatic setting, we see anywhere between 10 to 15% rate of ILD, and in the adjuvant curative setting, this becomes even more important to address. So the rates of ILD were relatively low, 4.4% in the T-DXd arm, and surprisingly to me, 5.1% in the dose-dense AC-THP arm. Most of that ILD was grade 2 with very little grade 3 ILD, although 1 patient from each arm had grade 5 ILD. The median time of onset was 82 days with T-DXd and 77 days with dose-dense AC-THP, and that's relatively similar to what we see in the metastatic setting as well. So it seems from this analysis that giving 4 cycles of T-DXd is producing much lower rates of ILD compared to what we've seen in the metastatic setting, which with much longer exposure to T-DXd. And when looking again at the treatment discontinuation and the reason for treatment discontinuation, ILD was a big reason here. And there definitely were also some treatment interruptions because of ILD. As far as steroidal use, as you can imagine, there was more steroidal use in the T-DXd arm compared to the dose-dense AC-THP arm because of the ILD pneumonitis. So 50% of patients with grade 1 ILD received corticosteroid compared to only 16%. And then with higher rates of ILD, the use of corticosteroids was much higher. As far as other AEs and management, there was more left ventricular dysfunction seen in the dose-dense AC-THP arm compared to T-DXd. That's pretty expected. And there was more nausea and vomiting in the T-DXd arm. But when looking at the use of antiemetics, they were more likely to be using 3 or more antiemetics in the dose-dense AC-THP arm. Now, this is important because these trials are global trials. The standards that we have in the US as far as using antiemetics are not the same as the standards that are being used in the rest of the world. And we know that T-DXd is considered a highly emetogenic regimen. We should be using 3 to 4, preferably 4 antiemetics, including olanzapine for our patients. This is not standard of care in many other parts of the world. So this is what is affecting the rates of nausea and vomiting in these global trials. And as far as peripheral neuropathy, it was more common with T-DXd, but those events were relatively low grade.
Virginia or Sara, any final comments or extra details about any of the data we've looked at, or final thoughts about San Antonio?
Well, I was actually going to ask how you interpret DB11 and 05 and what you're planning on doing in practice, assuming this agent will get approved in the neoadjuvant and adjuvant setting.
Yeah, not an easy question. I'm not sure that there's a correct answer. Obviously, DB11 gives us the option to give sequentially 4 cycles of T-DXd followed by THP and results in a significant improvement in PCR compared to our normal approach. One could argue that control arm wasn't maybe ideal compared to what we're using in the US, but to be honest, we know ACTHP performs just as well as TCHP, so I did think this was a significant improvement. And whereas on DB05, T-DXd really did a lot better than TDM1 in the residual disease high-risk setting. And so the way I've been thinking about it is that if you give it pre-op to a really high-risk patient, you can improve PCR and get away with just 4 cycles of T-DXd. And the rates of toxicity were a lot less than I was anticipating with pre-op T-DXd. To only see a little over a 4% ILD rate, and in fact, half of that was driven by the taxane component, is actually pretty impressive. So I think if I had a really high-risk patient in the upfront setting, I probably would want to give sequential therapy. And, for someone who maybe had lower risk disease up front and you didn't give them T-DXd, then certainly if they end up with a lot of residual disease, node positive disease, and you can always give them T-DXd out back. It's a lot of T-DXd in a DB05 setting, 14 doses, almost 10% ILD rate. And, if you could avoid that, that would be nice and still achieve excellent outcomes. But in truth, I think what we all feel is we want a biomarker because not everyone needs T-DXd. I think, if we could select the people who get away with THP up front, that would be great. And then they don't need any T-DXd at all the whole time. And you've cured the majority of your HER2 positive patients. So hopefully we'll get there. It's a complicated setting, but nice to have so many choices.
Thank you, Dr. Tolaney and Dr. Kaklamani, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, CCO Independent Conference highlights of the 2025 San Antonio Breast Cancer Symposium, and to access online content associated with this discussion, please click the link in the show notes. Thanks for listening.